Hi, everyone. Welcome back to the DocTalk Podcast. I'm Dr. Sheila Wijayasinghe.
And I'm Dr. Shazma Mathani. So normally we do a quick little check-in at the beginning of each episode, but we have so much to cover today, we're just going to jump right in.
So today we're talking about diabetes. This is inspired by a listener's question that came to us. And this is something that Shaz and I both see in our workplaces, and it's such an important topic. So we're really grateful for Paolo for sending in this question. So let's take a listen.
Hey docs, diabetes runs in my family, and I've already seen one of my loved ones have eye issues and another have kidney problems as a result. What can I do to lower the risk of diabetes and its complications?
What a great question with so many different components to it that we're going to cover today. So I think before we get started, it's really important to have a good understanding of what diabetes actually is. So at its most basic definition, diabetes is a persistently high blood sugar. And this can be for two main reasons. Either that the body doesn't make enough insulin, so that's type 1 diabetes, or that the body no longer responds to insulin like it should, and that's type 2 diabetes. And insulin, for those who aren't sure, is the hormone in our body that helps regulate and kind of determine how glucose or sugar is used in our body.
And I think it's really important to provide some context here, Shaz, because we see it really commonly. This is one of the most common things that people come to see us for in the family practice setting. But, in Canada, 1 in 3 Canadians are affected by diabetes or pre-diabetes. So 3.5 million Canadians have a diagnosis of type 1 diabetes or type 2 diabetes. And this number is actually expected to rise to 1 in 2 Canadians in the next year.
Wow.
So it's really rising. And this is why I'm really grateful for Paolo for sending us this question, because it really does demonstrate that these are rising numbers. And there are things that we can do to try to support our patients and the general population around this. When we break things down further, type 1 diabetes accounts for about 10% of diagnosed cases, and type 2 diabetes makes up the remaining 90% of cases. So let's talk a little bit about the risk factors for diabetes, Shaz.
Yeah, and I think that's an important piece, because for me, when I think about risk factors, it's like maybe there are things that we can change, right? Whether it's for diabetes or, other things we've talked about, like our episode on colorectal cancer. It's really important, I think, for our listeners to know what the risk factors are, to see if there's anything that they can do to help mitigate them. And so as we always do, we kind of break risk factors down into what we would call modifiable risk factors, which are things that you can make a difference on, and then non-modifiable risk factors, which are things that we don't have control over. So in terms of modifiable risk factors, some of the most important ones are weight. So the rate of diabetes does increase with increasing body weight. Things like physical inactivity, a diet that's high in refined sugars and saturated fat, high blood pressure, high cholesterol, and smoking. So these are all things that are modifiable risk factors. Then, of course, there's all these things that we can't necessarily control. So that includes things like age. So the highest rate of diabetes is actually over the age of 65. And, as much as we would like to maybe be able to turn back time and control our age, that is something, of course, that is not in our control. There are certain groups that do have a higher incidence of diabetes. So Indigenous peoples, South Asian, African, and Hispanic populations all are at higher risk of diabetes. Other genetics and family history can certainly play a role, and things like PCOS can also increase the risk of diabetes. And so that whole second section are things that we really don't have control over.
For sure. And, I can reflect on this, like my family background is Sri Lankan Canadian, and most of my family members and my extended family have diabetes. And so this is something that's on the forefront of my mind all the time around what my own risk factors are, what my kids' risk factors are as a result. So it's really important. And I love that we're touching upon modifiable risk factors, because there are things that we can do about it, like you said, and there are ways that we can reduce our risk. Going back to, again, Paolo's question, that we can do to reduce our risk. And so those are things like staying active, maintaining a healthy body weight, eating a healthy, balanced diet, working with a dietitian, potentially working with a trainer. That can also be helpful. And then also, really importantly, modifiable risk factors include things like our blood pressure and our cholesterol, which can all reduce the risks associated with diabetes as well.
And can you expand a bit more on that? Because I think, like, you see a lot of people in your office, and I do kind of want to get more into like how you decide who to test and that sort of thing. But like when you're counseling patients on those modifiable risk factors, even just exercise, I think people probably have maybe a misconception about like what that exercise truly means. And so when you're counseling your patients on being more active and kind of taking that physical inactivity risk factor out of it, like what kind of things do you talk to them about?
Sure. So that's a great question. And I think it can be really overwhelming for people to think about being active. If it's not something that's part of their regular routine. But I say, listen, let's like break it down into snack size, bite-sized things that we can do. So ideally, what you would be doing for activity is about 150 minutes a week of activity, not all at once, but like spread out throughout the entire week. So if you can get 20 to 30 minutes in 5 to 6 days a week, you're going to reach that target. And it's not that you're going to start running a marathon or doing those things. I sort of say, listen, walking is a form of exercise. Setting your watch to 10 minutes that you're going to go out for 10 minutes and come back in 10 minutes, that's 20 minutes of activity, and really breaking it down and figuring out ways to incorporate activity. So if you're parking your car somewhere, park a little bit further. If you're going to, then it adds a little bit of extra time to walk. The other thing that also really helps is reduction of body fat content also, because we know that does influence our insulin resistance, meaning how our body responds to the hormone insulin. So if you can do things incorporating not just cardiovascular exercise being that 150 minutes of moderate level exercise, again, those things are walking, dancing, running, a light jog, but also incorporating strength training into your routine, ideally about 2 to 3 times a week. That can also be super helpful in reducing your body fat content and increasing your muscle mass, which then also helps you to uses sugar really well. And so that's a really helpful tip that I always tell my patients. But again, bite-sized changes make a big difference over time, and then you'll start to feel better, and then hopefully that'll also help in the long run.
Yeah. And I think that strength training one really resonates with me, because when I like that, I love doing cardio, and strength training is so hard for me to fit in, because I'm like, oh, I'm just going to go play tennis. Like I love, or like go for a run with a friend. And these are all things that I love to do. But one of the things that I think has really, it has been a barrier for me is like the duration of strength training. Cause I'm like, oh, if I'm going to get a strength workout in, I'm going to like work for 45 to 60 minutes. And like, you don't have to do that, right? Even like doing 15 to 20 minutes multiple times a week is more than enough and has such a positive impact. And so I need to kind of like train my brain around thinking about that in a different way, because, you know, if you're someone that's used to exercise and you like really want to get a good workout in, like thinking about like 15 or 20 minutes doesn't necessarily feel like it's doing something when it actually is.
Absolutely it is. And you don't want to actually do too much too. You need to allow your body to heal in between these sessions. I have some of my patients, I said they share with me what they do. And I love it, because they say, you know, when I'm making dinner and there's like something in the oven, I'm just going to do some squats in front of the oven. And I do like 5 minutes of squats at that moment. And then I do 5 minutes of a little bit of an ab workout while the kids are in the bathtub and I'm like lying on the bathroom floor, but also doing crunches. Like there's different ways that you can incorporate it. We're all busy. We all have different responsibilities, but short bite-sized moments of exercise really make a big difference in the long run. And it also allows you to heal and get it in.
One little tip that I want to give is whenever I want to watch TV, that's when I get on the bike. So like my stationary bike, I have my iPad or like a little TV in front. And like when I want to watch TV, I'm like, okay, well, if I'm going to just like, I'm not going to sit and watch TV. I'm just going to like get on the bike, and like, it's a gentle ride and I just like move my body a little bit. So like, that's another tip to think about.
This is the ultimate in multitasking. Which is
yes, exactly. Exactly. So Sheila, I mean, when we think about diagnosing diabetes, like you're definitely a lot more likely to see the diagnosis of diabetes in your office. And so can you give us a sense of like how you decide who to test? And then when you do, how is diabetes actually diagnosed?
For sure. So, you know, type 1 diabetes is more often diagnosed in the younger age groups. And this is something that you likely actually see more than I do in the emergency room, because people are presenting in a very serious condition called DKA or diabetic ketoacidosis. So I think we're going to get to that as well.
Yeah. Mm-hmm.
But what I see often in my practice is more the type 2 diabetes, which is often diagnosed in, you know, adults and sometimes in adolescents as well. And this is related to something called insulin resistance. So it means that over time, our body's cells become less responsive to the effects of insulin. And insulin is the hormone that is released from the pancreas that helps to use your sugar, basically, that you consume. And it helps. So when you eat something, insulin is released in order to metabolize that sugar. But over time, sometimes in adults, especially, we can see that their body isn't as responsive to insulin as it was in the past. And as a result, the glucose or sugar isn't used. And then it results in high levels of blood sugar circulating in your body. How we diagnose diabetes is with a blood test. And there's 2 ways that I approach this. So if people are presenting, and this is more the rare situation, that they're actually symptomatic. So symptoms of high blood sugar can include things like increased levels of thirst. You're going to wash your, like you're urinating more frequently. You're very thirsty because you are urinating so frequently. That's all resulting from the high blood sugar. You can also get numbness or tingling in your fingers or toes. So glove and stocking, it's called distribution. So your hands and your feet, you could get numbness or tingling. You can also get things like visual changes where you're getting blurry vision. So if my patients are presenting with symptoms of diabetes, then it prompts me to do a blood test. In some situations, though, in the majority of cases, people don't necessarily have symptoms, but we're doing routine screening with a fasting blood sugar test or something called your hemoglobin A1C. And when we test that, we can see based on certain criteria. So if your fasting blood sugar is above 7, that tells me something's not right there. That might be an indication of diabetes. We never diagnose diabetes on one test. We have to do a repeat test, just to do something called confirmatory testing, just to make sure that it's actually diabetes. It's not a one-off thing that we're seeing. So if you are being told you have diabetes after one test, generally we have to repeat it again to confirm it. Hemoglobin A1C is a reflection of your blood sugar over a 3-month period of time. So basically it's looking at the blood sugar coding your red blood cells. Red blood cells have a 3-month lifespan. And so we test that to give us a sense of what is your blood sugar like over a 3-month period of time. Whereas your fasting blood sugar is a one-time, like in that moment, what is your blood sugar? And then we use that criteria to decide, are you diabetic or pre-diabetic potentially? And we go from there. We routinely test everybody in Canada at the age of 40 for diabetes. So we do that fasting blood sugar test or the hemoglobin A1C. But if you have risk factors, like you mentioned earlier, Shaz, we'll test people earlier for diabetes.
Yeah. And so, you mentioned type 1 diabetes, and that is something that, like you said, I probably see a lot more working in the emergency department because they do present a little bit differently. And so when we talk about type 2 diabetes, like you talked about, it's kind of like definitely more gradual, I would say, in terms of that resistance building over time in terms of the response of the body to insulin. Whereas type 1 diabetes, the kind of reason that it happens is because the pancreas, which is where insulin is secreted, stops actually producing that insulin. And so most of type 1 diabetes is thought to be an autoimmune condition where there's an autoimmune destruction of the cells that secrete insulin. And so that drop in insulin tends to be a lot more abrupt than in type 2 diabetes. And so because of that, the presentation can be a bit more severe and they can present in something called diabetic ketoacidosis. So I'm going to nerd out a little bit here on this just to kind of help explain it. And so in patients, so as we've kind of talked about, insulin, it has a role of essentially allowing glucose to go into the cells and the body to use it. That's what the importance of insulin is. And so if you don't have insulin, your blood sugar goes high because it doesn't actually get absorbed into your cells to get utilized. And so that can lead to a few symptoms that I often see people present with. And so that can be increased thirst, like you mentioned. So drinking a lot of water, peeing a lot more, and losing weight as well. And those can be like pretty subtle signs at the beginning. Especially if you let's say you have a child who's like an athlete or like already drinks a lot of water, is already peeing a lot. Maybe they just had an illness and they're like more fatigued. Like those things don't necessarily trigger warning bells to go into hospital. And so as that kind of lingers along, the body starts using fatty acids to get energy instead of glucose because it can't use that glucose anymore. And then that's where things become problematic because that can cause lots of metabolic disturbances in the body and lead to a severe state of acidosis. It can lead to a decreased level of consciousness. It can cause someone to get really, really, really sick. And that's when, parents usually will bring their children, older kids, adolescents, even into teenagerhood, into the ER. And they definitely have like a very specific look. We ask about these things, when I hear like, yeah, my child has been drinking a lot more, they've been more thirsty, they're peeing a lot more, and now they've just been getting more and more tired. And then that fourth kind of hallmark is that they have this fruity smell to their breath because of the ketones that they're putting out after using fatty acids, their body's using fatty acids. And so that kind of constellation of symptoms immediately makes us think, is this diabetes? Is this DKA? And so these patients can come in really sick, and it's often because it's so abrupt, it can be the first presentation of diabetes in these type 1 diabetes patients.
And I imagine that's very scary to see as well because they're very sick from what you're saying.
Absolutely. So these sometimes are some of the sickest kids that I've seen, like super, super dehydrated, really low pH in their blood, which is bad. And the shocking part often is that, this parents and the patients didn't know up until that day that the patient or the child even had diabetes to begin with. And then this is the first diagnosis. So like DK is like one of those like really serious acute complications. In type 2 diabetes, there's like a similar related phenomenon, to DK with like prolonged blood sugar over time that we see in the emerge as well. But there are also lots of longer term complications, that kind of smolder over time. And you likely see, I see some complications of them, but like there are lots more things that I think in terms of the chronic complications that you tend to see in your office. So can you tell us a little bit more about those, Sheila?
Sure. I think it really speaks to when someone's diagnosed with type 2 diabetes, our thought is that they've probably had diabetes for several years, or like the early signs or pre-diabetes for several years. And this is sort of a smoldering change that has happened. As a result, we are seeing the complications. And this is actually why we aggressively treat diabetes, is to reduce the risk of complications of the disease. So it's not just the blood sugar control that we're trying to manage, but it's actually reduction. If we can manage the blood sugar, we're reducing the risks of complications of diabetes, which have huge morbidity, meaning that they have a huge impact on our patients' quality of life. And people
and mortality, right?
And
like
mortality.
Those are things that will decrease the lifespan of patients with diabetes too.
100%, right? And so, like you said, with type 1 diabetes, and I think what's a nice, important thing to note, often we think that type 1 diabetes is genetically mediated, and actually type 2 is more genetic. So if you have a family history of type 2, you are more likely to have type 2, whereas type 1 doesn't have that same genetic predisposition. Whereas I think that's because it's a younger presenting disease, we assume that it is a genetic condition, but really type 2 is much more genetic. So when we go back to the complications, like you said, it can have definitely, and we talk about this, it's the leading cause of blindness, and it's the leading cause of kidney disease, and dialysis is diabetes. And then it's one of the leading causes of heart disease. And they're so significant, these risk factors. Patients with diabetes are 2 to 4 more times likely to develop heart disease and coronary artery disease, which increases the risk of heart attack and heart failure. They are also 2 to 4 times more likely to have a stroke, and we also then know that chronically high blood sugars can really affect your vision, as I mentioned. That's one of the leading causes of blindness in Canadians. It is also can affect the kidneys, which is the leading cause of dialysis, I mentioned. It also can affect the nerves. It can affect how your sensation is. You lose sensation in your feet, potentially, or your hands. It also can affect the nerve function in your gut. And so you can have a slowing of your gut function. You probably see this in the emerge as well, Shaz, that people can't clear what they digest because things are slowed down, because the gut and our peristalsis, or our forward movement of food as it gets digested, can get slowed because of the nervous system changes that occur. And finally, again, I'm sure this is something that you also see in the emerge often, is the risk of infection goes up, especially with if the blood sugar is not controlled, you have a higher risk of infections of the skin and generally of all infections, which is why our patients with diabetes are considered higher risk when it comes to influenza, COVID, also, and all these other things that you will also see.
For sure. So how do you, what are ways in your office that you kind of monitor for these complications? Because as you mentioned, like these are things, it's not the blood sugar so much as like how the blood sugar affects all of those organs. So what are things that you do with your patients who do have diabetes or pre-diabetes in terms of kind of making sure that you're monitoring for and trying to prevent these complications?
For sure. So, we do very close monitoring by checking blood sugar levels every 3 to 6 months. And specifically, the blood sugar test that we're checking is that hemoglobin A1C that we talked about earlier, where it's a reflection of how good your blood sugar control is over the last 3 months. And then we try to target it to a specific number, because we know that if we can target it to low, like in younger individuals, it's below 6.5 is the number that we aim for, and even less if we can get that without compromising anybody or if they can tolerate their medications and not have side effects, for example. But we target to less than 6.5 because we can see that helps reduce the risk of these complications. If you're older or more frail, we tend to have a bit more flexibility with that number, because we have to balance the risks of over prescribing and over treating the blood sugar, because we can tip somebody into low blood sugars as well.
Right.
So we need to find that balance. So we tend to, like with our 70, 80-year-old patients or anybody who's frail, will tolerate sort of up to like a 7.5 to 8 on that hemoglobin A1C. The other side of things that you mentioned, Chaz, is, what else do we do for monitoring separate from blood work? So when someone is diagnosed with diabetes, we automatically refer to our colleagues who do eye care, so optometrists and ophthalmologists, because there's something called diabetic retinopathy, which is a disease of diabetes in the back of the eyes, the retina, which can really affect our vision. And so we do that once a year. You should be seen just to see if there's any complications of the eye related to diabetes as well. And then we also check your kidney function in the blood work as well, and a urine test to see if you may be spilling protein, for example, which is a early sign of diabetes affecting the kidneys. And these are all really symptoms of something called microvascular and macrovascular changes, which are basically diabetes is a disease of the blood vessels.
Yes.
And so we can see that. And one hallmark symptom that people don't always recognize are things, and can be that patients who come in and see us for erectile dysfunction, actually, that might be a sign of diabetes, because it's erectile dysfunction is a disease of the blood vessels, and diabetes is one of the leading causes of erectile dysfunction for folks. So if I have somebody coming in, this is a totally side note, but it can affect sexual function as well as a complication. But if I have someone coming in with ED, I'm also checking them for diabetes at the same time.
Yeah. And I like how you mentioned, I think that's a really important point, that I think a lot of people think of diabetes as an issue with blood sugar, but it is very much an issue or a disease of blood vessels, because of the profound detrimental effect that ongoing high blood sugar and kind of lack of response or utilization of insulin has on blood vessels, both like the tiny, tiny blood vessels, like the ones in our eyes, right? Or the bigger blood vessels, like the ones around our heart. And that's where we see this entire host of complications over the long term.
And you must see complications related to diabetes in the emerge all the time.
Absolutely. This is something that I see a lot in many different forms. And so, as an ER doctor, and for you as a family doctor as well, we see a lot of different things come in the door. And from an emergency perspective, I mean, the classic emergencies that people think of are things like heart attack and stroke. And so I see those every shift. And when I do, it is very rare for me not to see diabetes as a problem list on as kind of a past medical history of a patient that's coming in with either a heart attack or a stroke. And then even more commonly still, I see infectious complications of diabetes, like you mentioned. And so, you did talk about how the nerves can be affected. And so the reason that that's important is because as the blood sugar starts to deteriorate those nerves in our fingers and our feet in particular, you can't feel things. And so what ends up happening with these patients that have had longstanding diabetes, and then the complications of that is that, let's say they step on something or they scratch their foot. And the feet in particular, it's we don't look at our feet often, right? And so our hands are things that we look at all the time. And so if you see a little scratch, you can manage it. But the bottoms of the feet and kind of those areas that you don't see as often, when there's a scratch there, one of the other issues with diabetes is that the wound healing is impaired, which means that things heal a lot more slowly. And so let's say you get a little scratch or a little cut or a nick, you don't feel it. And then your wound isn't healing as well. And then it actually has a higher risk of getting infected because it's not healing as well. It's there for longer. You're not taking care of it in the way that you would if you could see the wound to begin with or knew that it was there. And then because of the negative immune function effects of diabetes as well, then you're at a higher risk of getting an infection on top of all of that as well. And so what ends up happening with these patients is that they start getting what's called diabetic foot ulcers or diabetic foot disease, where they get these quite severe kind of wounds and ulcers and infections on their feet. And even with antibiotics, they can be quite slow to heal because of the effect on immune function and because of the repeated infections that these patients can often get. They can start getting resistant bacteria that are in there as well. And so picking the right antibiotic can be challenging for them too. And over time, with these chronic ongoing kind of stacked infections in kind of the most severe worst case scenario, sometimes these infections can't be treated. They go down into the bone. And because of that poor blood supply already existing from the diabetes, sometimes the only option is amputation. And that can be extremely devastating for a patient. There are lots of times when there is that severe ulcer that's just not getting better, or there's, evidence of gangrene, which is really far gone in terms of infection. I have to call orthopedic surgery because the only option in these situations is doing an amputation, which is life-changing for these patients. And it really goes to show like why it's so important to see someone like you, Sheila, like, someone's family doctor, so that you can try to pay attention to those things, get good foot care, making sure that they're seeing their doctor regularly and kind of addressing and preventing these signs of infections. And then, of course, like the last kind of category of things that I see are kind of two more categories. I mean, one is decay that we talked about, and definitely see that more in the pediatric population. And then in adults, like a similar thing called HHS, which can happen in adults. But the big thing that you mentioned is that kidney disease. And so at the site that I work at in Edmonton, it's a big tertiary care center. So we have a big nephrology team there. And so there are lots of patients that come through who are dialysis patients. And I would say well over 95% of them, if not higher, have end-stage renal disease or renal disease that's requiring dialysis because of complications of diabetes. It's like one of, as you said, like the leading cause of chronic kidney disease in patients. And so we see that. And I see that and emerge quite a bit as well in terms of those acute complications of diabetes as well.
So I do think that we see quite a bit, and this is why it's so important that we're talking about it in primary care or family practice. We really approach diabetes, and I think it's the one area of care that it's a team-based approach to care. As you said, like we get a foot clinic involved. We have a chiropodist who does our nail care, because even cutting our own nails can be problematic sometimes, because if you don't feel ingrown nails or anything like that, it can lead to those sorts of things. So
or you can't feel if you nick your skin.
You can't feel it, yeah. Mm-hmm. And so we work with our diabetes nurses. We have dietitians who really help our team with our patients to kind of talk through how to make dietary changes to be helpful. So it's a real team-based approach, because, it can be scary to think about all of these potential complications. But the good news is that we can do things to try to reduce our risk and reduce these complications over time. There are many options that we have available. The good news of the diabetes story is that we have many great medications that are very effective at reducing your blood sugar, that are that protect your heart at the same time, that can support your weight loss journey as well. And there are many things that can be helpful. And so the good news is that we do have options. And if something doesn't seem to work for you when it comes down to medication options, that we're not going to get into the specifics here, because that is an individual discussion to have with your own provider. There are always other options that are available. Very briefly, the common medications that we use for diabetes are things like metformin. We do use insulin, which is injected. We have different types of medications, and the common ones that people really talk about right now, which is making a big splash in the news regularly, is Ozempic. That's actually originally a medication that we use for diabetes, but it's been used now for weight loss support. But it's originally a diabetes medication and quite effective, and it has some protection also for the heart. It's been found, which we know, again, diabetes increases the risk of heart disease. So if we can get that bonus protection of the heart, that's also really helpful. So we have many options for medications. We have many lifestyle modifications that we can make. So we wanted to address this today and answer Paula's question, because while, it's important to address that there are complications of diabetes, there are things that we can do and support you to reduce those risks.
Yeah. And I mean, that kind of, it's so important to kind of talk about that we never want to scare our listeners. The whole point of having these episodes is to make you all aware. And so you can be aware for things for yourself, for your loved ones around you, and then understand what you can do to help mitigate risk factors. And so kind of to that end, we'd love to take it back to our listeners' questions, to Paula's question, to leave our prescription for today. And so the first step, of course, for everything, and especially in this case, is be aware of the risk. And so whether that's based on your family history or kind of other modifiable risk factors, and then identifying what those are. And then, of course, then taking the next steps to protect yourself by emphasizing a healthy diet, lifestyle, and regular exercise. It's also important to consider testing either after the age of 40 and above, if you're kind of have a normal risk, or if, of course, you are at higher risk of diabetes from the things that you mentioned, to get tested sooner, because the earlier we diagnose it, the quicker we can get that blood sugar under control, and the better we can prevent those complications down the road.
For sure. And just really briefly to just re-summarize, because I didn't get to specifically say what those extra risk factors are. for if you want to test before age 40. So if you know your risk factors, but the things that can increase your risk that can change my decision to test you earlier in the office in a family practice is if you have a higher BMI, if you have a family history, if you have a history of gestational diabetes, so if you're in pregnancy, you had diabetes, if you have other cardiovascular risk factors or heart disease risk factors like high blood pressure, high cholesterol, if you smoke, I'm going to consider, and polycystic ovaries as well. Those are all reasons why we will test earlier. So I'm grateful to the question that came in today. This diabetes, as I mentioned, Shaz, is something I think about often because many of my family members have this. One resource I share with my patients, just to close off, is that it's the Canadian Diabetes Association has a wonderful website called the diabetes.ca, and you can go there to learn more about diabetes. There's lots of tools on there. There's exercise programs on there that you can do that are free and really helpful to help navigate diabetes and how to reduce your risk.
Thank you so much. And thank you everyone for tuning into the Doc Talk today. We did cover a lot. A reminder that the Doc Talk, of course, is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. So always speak to your own healthcare provider for questions related to your own personal health and needs.
A big thank you to our sponsor of today's episode, Always Discreet. You know, Shaz and I know that our patients will often share that if they sneeze or laugh too hard, or even during a workout, there can be bladder leakage. There's no shame in this, and there are solutions. Please know that you're not alone, and there's no need to worry. Always Discreet is here for you. Many women experience urinary incontinence as they go through perimenopause and menopause. Nearly half of us may encounter leaks or accidents during this time. And by age 65, about 75% of women report experiencing some form of urine leakage. Yet it's a topic that we rarely discuss.
Always Discreet's Rapid Dry Core locks away even the biggest leaks with no wetness, no odor, and no visible lines, allowing you to stay active and confident. They stay in place comfortably and remain invisible under clothing. Check out the link in the description for an Always Discreet coupon and step confidently into this new chapter. Always Discreet, your dependable solution for bladder leaks.